Hello, my name is Nissa Cole and I am a clinical nurse advisor with Medicare Plus. And I'm here today to talk to you about the difference between pressure ulcers and moisture associated skin damage, specifically incontinence associated dermatitis, because incontinence associated dermatitis is a recognized risk factor for pressure ulcers, and the two conditions can coexist together in one individual. But there's still some confusion as to what is a pressure ulcer and what is incontinence associated dermatitis. So hopefully after this presentation, you'll have a bit of a better understanding. So let me get going with it. Now, why is it important to know the difference? Because the prevention and the treatment strategies are very, very different. And pressure ulcers are linked to moisture-associated skin damage, but essentially they are pathologically different conditions. The skin damage that's caused by moisture-associated skin damage or incontinence-associated dermatitis can damage the skin, particularly around that sacral area, and then can lead to increased friction and damage to the skin, which can then lead on to pressure ulcers. So the two can coexist together. However, the treatment is very, very different. So the actual number of pressure ulcers and moisture associated skin damage can be inflated if we don't know what we're dealing with. And obviously the treatment is very, very important for that patient, and if we don't get that right, then we're not providing the best care that we can do for that person. And obviously the cost implications as well, because the treatment again is very, very different, and the cost of those treatments can be very, very different. So for example, if you're looking at a tube of cream compared to hiring an air mattress, obviously they're going to be significantly different. So we're just going to have a quick look at what moisture associated skin damage is, because we categorize it in 4 different ways. The first being intertrigo, which is caused by perspiration, so prolonged exposure to that perspiration, quite often under the skin folds, under the breasts, can be in the folds of your abdomen, behind your knees, especially if people have contractures as well, especially at the hands, it can cause significant problems there. We have peri-wound dermatitis. Now, the exudate from wounds is a normal part of the healing process. It's part of the inflammatory phase of healing. But when you have chronic wounds that aren't healing, that exudate can be quite toxic to that surrounding skin. It's higher in those proteolytic enzymes. So we have to be really careful to protect that surrounding skin. We then have peristomal dermatitis, and peristomal dermatitis is obviously caused by that output from that stoma. That skin is continuously exposed to either urine or feces, and can really affect that skin. So it can be quite difficult when people first have their surgery and they first get used to those lifestyle changes, but that can cause a problem with the skin there. And then we have incontinence associated dermatitis, obviously that prolonged exposure to urine or feces. And if we have that double incontinence, then we're significantly increasing that risk of causing further damage to the skin. And incontinence associated dermatitis is essentially just an inflammatory condition. It's where the urine is drawn into the cells. It causes the cells in the skin cells to overhydrate and swell. You can see that visibly as maceration to the skin. And when the skin is exposed for longer periods of time, the bacteria then convert the urea to ammonia, disrupting the acid mantle of the skin, increasing the risk of infection, increasing the risk of breakdown of the skin, increasing the risk of skin tears, skin friction, and then pressure ulcers and infection. So it's really, really important. And it's a really big problem, especially in long-term care settings, because it's estimated that there's over 14 million people in the UK that have incontinence. So it is a very, very big problem, and it can cause significant pain and can cause significant infections and problems with the skin. And when you think about it, what we've done with incontinence associated dermatitis is we've eroded that top layer of skin, that epithelial layer, and we're exposing the dermal layer, which is where all of those nerve endings, which loop up and down in the skin like this, they're going to be then exposed to that surface. So that's where we can get this incredible amount of pain from, because we're exposing those nerve endings. So it can be incredibly painful, and we need to replace that barrier to help that skin heal and prevent any further damage. So the difference between pressure ulcers and incontinence associated dermatitis, there's quite a few significant areas that we can look at. This resource is available for you to download in your clinical areas, and I'm more than happy to send out posters to you. But if we quickly have a look through the different areas that we would look at really to differentiate the two. So the location. So for pressure damage, it's likely to be over a bony prominence. Moisture-associated skin damage will occur over a bony prominence, but is likely to be in that anal cleft and in those creases in the groin, as you can see, the two different areas. Then we have the shape and edges. So the shape of a pressure ulcer tends to be quite defined around the edges, whereas with incontinence-associated dermatitis, it's very scattered. There's no specific pattern. It does tend to be mirrored on both sides, but it doesn't have to be. But you can see from the images that they're significantly different. Then we have the colour as well. So pressure ulcers, as you know, can be all sorts of different colours. So they can range from red, yellow, pink, black, green, blue, purple. So, a whole range of different colours. Whereas with moisture-associated skin damage, it only involves that superficial layer. So the wound is only ever going to be pink or red, or you might see some white areas where we've got that maceration. So if the wound is looking any other color than red or pink, then we need to consider that being a pressure ulcer. As you can see from that image, there's a bit of a purpley tinge to that skin where the damage is occurring from underneath. The depth, obviously pressure ulcers can go right through to the bone. So, and they can involve all sorts of muscle tendons and really significant damage to the tissue. Whereas with moisture-associated skin damage, it's only ever going to be very superficial. It's only ever going to involve that epithelial layer, and obviously when there's infection present, that it can spread, but it will only ever be that superficial layer. And then if there's necrotic tissue present, that indicates that there's a pressure ulcer there, because of the pathology of pressure ulcers. Necrosis indicates that there's a problem to that blood supply to that tissue. That tissue has now died, and that is the necrotic tissue. Whereas moisture-associated skin damage does not contain necrotic tissue, because the damage occurs from above. So the urine is affecting that acid mantle and that barrier of the skin and that epithelial layer, whereas pressure ulcers happen from underneath. So that's the damage to that blood supply to that tissue. So you have to kind of think of it as the two different ways. So once we know that we're dealing with moisture-associated skin damage, what we need to do is look at a good skincare regime. And ideally, if we're managing that incontinence, in an ideal world, we would get rid of that incontinence. So, we would look at catheters. Are they wearing the correct incontinence pads? Do they have a catheter care plan? Have they had a referral to the continence team? All of those kind of things to manage the problem in the first place. And when we know that we're doing absolutely everything that we can, then it's about implementing a really good skincare regime. And I'll just say here that barrier products and skincare alone will not prevent pressure ulcers. So I hear this quite a lot, in that, you know, people will use the cream on the pressure ulcers. It will help with the skin integrity, and it will help with the skin health and that barrier protection. But the only thing that is going to relieve pressure ulcers is pressure relieving equipment or manual handling procedures. So we cannot just use skincare products alone. But skincare products and barrier skincare products specifically are brilliant for managing moisture-associated skin damage. So first of all, we'd look at cleansing the skin. Obviously, if you're dealing with incontinence, you're probably going to be cleansing the skin a lot more than what you normally would do. And it's really, really important to use a pH correct cleanser. So traditionally, you know, we would use soaps, but soaps can be very alkaline, and that can affect the acid mantle of the skin. And what we don't want to do is disrupt that acid mantle of the skin, because that acid mantle is going to provide that protection. It's going to stop those invading microbiomes getting into the skin and keep that skin flora nice and healthy. So we want to keep the acid mantle as healthy as we can. And the acid mantle of your skin will be slightly acidic. And by using products that are not pH correct, most high street products won't be pH correct purely because of the chemical components of them. That will then affect the acid mantle. So it's really, really important, if you want healthy skin, to use pH correct products, and especially if you have somebody that has vulnerable skin and skin integrity issues, using traditional soaps is not ideal. So we would cleanse the skin with a pH correct cleanser, and again, just being really gentle. We don't need to rub the skin, pat dry or air dry if possible. And really in those skin folds as well, making sure that they're completely dry before those skin folds are allowed to close, so that we're not trapping any unnecessary moisture in there. So making sure the skin is completely dry. And then looking at hydration. So hydrating from the inside out, because skin that is dry is more prone to infection. So we really need to be careful that we're hydrating the skin, using emollient creams to keep that moisture locked in, and using the emollients as a soap substitute as well for cleansing is a really, really great idea if you don't have any pH correct cleansers. But what we wouldn't use the emollient creams on is moisture associated skin damage. So anything that is caused by, damage that's caused by moisture, we wouldn't want to add to that. So emollients are designed to keep that moisture in. We want to keep that moisture out. So what we would be looking at is replacing that barrier and providing some sort of protection for the skin. And traditionally, what we would use is these zinc oxide creams. And back in the day, they were brilliant because that was all we had. That was all we knew. But as we know, in healthcare and in medicine, things change all of the time. We have better research, better gold standard products and gold standard care that we should be adhering to provide the best optimum treatment and care to our patients. And there's 3 reasons why I don't advocate the use of these products anymore. The first reason is that in with skin integrity, we need to be really, really careful, and we need to assess that skin every day, minimum once a day, ideally twice a day. But if you've got wounds, you might need to increase that as well. But if you've applied these zinc oxide creams, you're not going to be able to inspect that skin, and how quickly your skin can change. So you can see a person in the morning and think, that skin looks a bit red, I need to keep an eye on that. But actually by the evening it's broken down. Now, if you've got cream like this on that skin, you're not going to be able to assess that skin at any point. You're going to have to remove it to assess that skin. And this brings me on to my second point. If you've ever had to remove this product, you will know that you cannot remove it gently. You will have to use force to remove this product, and then you're potentially just damaging any skin and any healing that's happening underneath, which is going to just cause more pain and disruption to your patient. And then the third reason is that it interferes with the absorbency of pads. So if you're using this on somebody that is incontinent, then you're using an incontinent pad. We're essentially just increasing the chances of that person sat in their own urine and causing potentially more problems. So what we have now is better gold standard products that we can use, that will replace that skin barrier, and we'll go on to those in a moment. But I just want to bring your attention to this skin moisture alert reporting tool. Hopefully you'll have all seen this before, but if you haven't, it's essentially what we call a smart tool, and it was designed by a nurse here at Medicare Plus, and it's been endorsed and recognised by NICE guidelines as a tool for any level of healthcare professional to be able to assess and categorize and treat moisture associated skin damage. So it really just gives you a simple guide as to whether we're classifying this moisture as mild, moderate, or severe skin damage, and then what we're going to do about it. So giving you the treatment options that you have. So here at Medicare Plus, we've got a range of products for moisture associated skin damage. There's something for everyone, which is what I love, because there's a whole range, something in your toolkit for everything. The first what we have is the cream, the Mediderma S barrier cream. Now, this is indicated for mild skin damage. So mild skin damage is where the skin is starting to become red, starting to become inflamed, and we want to provide that protection. You don't actually have to wait for the skin to go red. You can use it as a preventative as well if you have somebody that you know is at significant risk. But we would tend to just use it on that mild skin damage, that intact skin. And the skin really ideally needs to be completely dry, because you're not going to be able to get the product to dry on the skin and provide that barrier if the skin is already wet. So for that reason, it's not really indicated for intertrigo, so you wouldn't apply it to those sweaty areas. We wouldn't use it on stomas or in wound care, really. It's more for incontinence associated dermatitis. So making sure that the skin is completely dry before you apply it. And my biggest tip for you is, and this goes for every product actually, is that we only need to use the minimal amount. So everybody's guilty of it. We use lots and lots of product, but actually we only need to use the tiniest amount. So what we recommend is a pea-sized amount to a palm-sized area. So the tiniest amount, and then you rub it in. And the way that you know that it's you've applied the correct amount is that it should be dry within 30 to 60 seconds. And if it's not dry in 30 to 60 seconds, you've got too much product on. Because you should be able to put any adhesive dressing on top of this, any not that you'd use it in stoma, but you should be able to put a stoma bag on top. It should be providing that barrier, but also able to have that adhesive product on top as well. With the cream, you also only need to apply it once or twice a day. A maximum would be every 3 washes. If you had someone that was doubly incontinent and you were increasing the amount of personal care that you were providing, you could use it every 3 washes. But the beauty of these products is that because they're silicone based and they're transparent, you can apply it and you can see the skin at all times. But the downside to that is that sometimes you feel that the skin isn't protected because you can't see that it's there, but it is there. It will naturally wash and wear off, and you only really need to apply it once or twice a day. If you do feel that you need to apply more cream to protect the skin, I would be inclined to step up to our barrier film products. Now, I love the barrier film products because they're really suitable for absolutely everything. Mild to moderate skin damage. So moderate is when the redness is starting to increase and the skin has started to break down. And this can be caused by incontinence. We can use this in wound care, peri-wounds, brilliant for that intertrigo, that perspiration, used a lot in stoma care as well. And what's great about the film is that it comes in an applicator, which is quite often referred to as a lollipop. It comes in a spray, and it also comes in a wipe form. So there's lots of different methods of application. So it's, there's really a product that's suitable for every type of wound or person or patient. And what's great about this is that it's a better choice for that wet skin. So you can apply it to already wet skin, and it will dry within 10 to 15 seconds. So it's really great for, those areas, especially under those skin folds, because like I said earlier, you need to make sure that they're dry, and the product is dry before you allow that skin fold to fold back up. So having a dry rate of 10 to 15 seconds is brilliant, is perfect. And it can also be used for prevention of skin trauma. So if you know that you've got somebody that's got vulnerable skin, and you're applying an adhesive dressing, as in stoma care, you can apply the film spray, then apply the adhesive dressing, and the film will protect the skin when that adhesive dressing is removed. So it prevents that marcy of the skin. Brilliant for all those difficult to reach areas, and the film will last for up to 72 hours. So you only need to apply it once every 3 days. So it's perfect underneath those stomas, and it's perfect underneath those wound dressings. So that skin is going to be protected for those 3 days. The maximum that you would use this product is once every day. Definitely no more than that, because we don't want to have a buildup of the product on the skin. It will wash off and wear off naturally. Again, it's transparent, so you can't always see that it's on there, but it will be protecting the skin. And then finally, we have the skin cleanser and the ointment for the more severely damaged skin. And severely damaged skin we classify as, obviously, a large area of erythema. More than 50% of that skin will be broken, and it's likely to be bleeding and oozing and incredibly painful. So what we have is a no rinse moisturizing cleanser. The cleanser is pH correct, and it works as a spray. So you can spray it directly onto a cloth and cleanse the skin, or you can twist the nozzle on the product, spray it directly onto the skin, and it works as a bit more of a foam action. So if you need to leave it to soak on the skin, then you can leave it there to do its magic and then wipe it off. There's no need to rinse it off, so we're not adding any more water or any more moisture to the skin. And then we just allow the skin to dry, and then we will apply the ointment. Now, ointment is very different to the cream. Ointment is over 80% oil. And the reason for that is because we want to have a really good protective layer on the skin. And what we would do is we would apply it and we would dab it onto the skin. You're not going to be able to rub this product in. We're just going to gently dab it on. Well, firstly, the patient's not going to appreciate you rubbing anything into a wound like that. And with, the point of an ointment is that you can't rub it in. So some of it will soak into the skin, but it will just sit on the surface of the skin. And I like to think of it as a similar way that you would protect a burn. So if you had a burn to your skin, it's incredibly painful because those nerve endings are exposed. And so we would wrap it in cling film to seal those nerve endings and stop that pain. And this is what that ointment does. It seals those nerve endings and just gives a really good layer of protection on the skin. And you can use this at every single wash, as much as you like, as many times as you like. And ideally, what we'd like to see really is an improvement after a few days. We wouldn't expect to see this product on repeat prescription. The maximum we would expect someone to be using this for is sort of 14 days. Because if you have somebody with a wound like this, if it's not healing after 14 days, we need to figure out why. So is there a bacterial infection? Is there a fungal infection? Is there something else that we're missing that we need to be looking at? And that is another reason why these products are generally only available through your tissue viability teams or your continence teams, because you need some specialist input for wounds like this. It's, you know, we want to have that expert advice, and that helps supporting you with your patients with these types of wounds. So the great thing with the Medicare Plus is that we've got the range of products for mild, moderate, and severe. And when you have been doing your assessments and you notice an improvement, you can step it back down. So if you're using a film product and you notice that actually the skin's not broken anymore, you can then step it back down to a cream product. Likewise, if you're using a cream and you notice a deterioration, you can then step it back up and use a film product or the ointment. So you've always got something in your toolkit to help with the skin. So I think I have spoken enough. Normally I would say any questions, fire them at me, but obviously I'm not with you guys today, which I do apologize about. But please feel free to screenshot this slide. My email is at the bottom. I'm always happy to answer any questions that you have. And, you know, if there's any patients that you have that are particularly, you know, problematic, or you need some advice, I'm more than happy to help you with whatever queries or product questions that you do have. And if I can't help you, I would definitely find somebody that can. So I hope you found that helpful. Enjoy the rest of your day, and hopefully I will see you all very, very soon.